Hi friends, this is my final project. So for this, I chose to talk about the kind of general overview of multiple different little topics, but the umbrella topic is going to be kind of understanding how there are differences in healthcare based on gender, age, ethnicity, race, all that kind of stuff. So the main thing, and like this is a hill that I will die on because I've seen it happen firsthand, and my clinicals actually. Um, a DNR does not mean do not treat. A DNR stands for do not resuscitate. It is a legal document that is saying that the patient, once their heart stops beating, that they do not want CPR to be performed. Now that's different from a MOLST form. Don't ask me what that stands for. I don't remember. Um, but that a most form kind of expands upon that. So they can put that they don't want CPR, they don't want to be bagged, they don't want tube feedings or antibiotics or fluids or pain medications or whatever. So um, it's just a most form can get more specified down to like what specific things the person does not want, and it will specify when they don't want that. So if they don't want it while they're still alive, like if they're on palliative care, or if they don't want to be put on life support, and if they are on life support, they don't want those things to be done to them. Um, I've seen patients have both, but I've never seen someone have a DNR that has a MOLST form that does not have no CPR checked off on the MOLST form. In that point, I would just call med control, or if family says that they still want CPR to be done, it kind of gets into that weird legal gray area. So I would still contact med control in that kind of situation. Um, but I have seen it firsthand where you get on scene in the fire department. I'm not even kidding you. This is verbatim what happened. Um, I was doing clinical and we got on scene for this older lady. I think she was 90 or 80 something. Um, she had a DNR in the fire department. Their entire report to us after they had been on scene for like 15 minutes was she's 74% on a non rebreather at 15, but she has a DNR. So, again, a DNR means do not resuscitate, not do not treat. You should still be treating your patients just as you would performing any life saving interventions. Again, unless they have a MOLST form that says they don't want specific things. Obviously, it's a legal document, you have to obey that. But that's saying after they die they don't want to be brought back or attempted to be brought back. And that kind of leads me to my next topic of, this is just my personal opinion, but people that are on hospice, people that have terminal illnesses and things, that are on life support, if they are not capable of making their own medical decisions, I personally think, and I know that I'm going to have a different view on this because I've been doing this for a couple years, and I am in healthcare, so I know I'm going to have a different view than someone who's not in healthcare. But people that do not want to get DNRs for their family members that are terminally ill or on hospice or on palliative care, or whatever it may be, that is selfish. I know that's going to be like a hot topic to some people, but I just know that if that was me and I was like terminally ill or on hospice or palliative care or something, and my parents, because I'm not married, my parents decided that they did not want a DNR for me, and something did happen, and all of that was done to my body, as in like CPR and bagging and drilled and intubated and all that kind of stuff. First of all, the chances of you coming back with CPR are so small, anyways. It's like 5 to 7%. Unless you're in Wake County, then it's like 13%. But like, the chances of you coming back are so slim. The chances of you coming back neurologically intact are so much slimmer than that. I think that is borderline abuse of a corpse. I know that people are going to have a very emotional attachment to people, and they're not going to want to do that for some people, but that's my biggest thing is, if Mima's 97, she's GCS coffee table, GCS 3. She's alert oriented to nothing, and like that's just it's her time to go. So like if something were to happen to her, like I would not want someone doing that to her. I wouldn't want, that's just unnecessary. I mean, if you've never seen CPR be done or done CPR yourself, you cannot understand how brutal it is. You are quite literally breaking someone's ribs, all of them, if you're doing it correctly. It's causing unnecessary trauma to their body by breaking their ribs, intubating them, anything that you do to them. While yes, we have good intention with it, high risk, not so high reward because the chances of them coming back are so slim. Um, so I just personally, I just feel like that's very, very selfish of people to not want to get DNRs for people. Now, it's one thing if the person is GCS 15 and they are their own power of attorney, or they have a medical power of attorney and they make decisions together, things like that. I mean, obviously, there's going to be exceptions to like every rule per se, but it's different if my parents are my medical power of attorney and we decide together that I don't want a DNR because I'm only 22 or whatever. Um, Doctors generally won't give DNRs to people that are super young, anyways, unless they have some like extenuating circumstances. Again, there's exceptions to every rule. I don't, to my knowledge, there's not a hard cutoff for what age they will start giving DNRs to people. But I know, like, I can't walk into my PCP's office and be like, "Hey, I want a DNR." He'd be like, "You're 22 and have no comorbidities." No. Um, but if someone is the sole medical decision maker for somebody and that person is hospice, palliative care, terminally ill, in my opinion, they should make the decision to have a DNR for them. Now, I can understand where if that is your mom, brother, family member, whatever, hopefully you're not medical power of attorney to someone that like you don't care about, but that does bring into the question, this is my mom, like I don't want to see her die, or my dad or brother or cousin, whatever. That I can understand, but also I still think that people need to look at it from a what would that person want type situation. Um, because personally, if something ever happened to me and I was on life support, I don't ever want to be on life support. If the chances of me coming back are like slim to none, or I'm going to be in a medically induced coma for the rest of my life, or not medically induced, just a coma, um, I want someone to pull the plug. Don't, I don't want that. I don't want to be a vegetable. No, thank you. That just does not seem like something I want to do. Um, all of that being said, very important. I don't know who's going to watch this aside from Raven, but please, for the love of all things holy, make sure that you have the original DNR. Make sure that it is the yellow one. Everything is filled out. The information is correct. Not working 911, but when I work transport, I have had facilities give me completely blank DNRs with no patient information, no doctor's name, no address, no date, nothing. Um, it's a very awkward conversation to have with people, but um, I try to ask family on scene, wherever scene is, um, if the patient does have a DNR, if it looks like they might. I mean, I'm not going to go ask someone who stubbed their toe and is 23, do they have a DNR? Chances are probably no. But like, if Mima is 87 and she's on home oxygen and she has like a home healthcare aide or whatever, I would ask. And make sure that you have the original copy. I have had facilities give me like photocopies of it. That's not gonna do anything. That is not it's not illegal, but that's not, doesn't satisfy the DNR rule. Like if you can't follow that. So if they hand you a photocopy, I have to have the original. If they don't have the original, then you just have to explain to them if something does happen on the way to the hospital, we are going to have to get a code response and start working a code on them. We have to have the original, it has to have the big red stop sign on it, has to have all the correct information on it. If there's not a um, expiration date on it, the box that says check here if no expiration, that needs to be checked. Um, the information on it needs to be correct. You need to make sure that everything's spelled correctly because it's a legal document at the end of the day. Um, it, like I said, it can be a very awkward conversation to have with people, but you would rather ask than not ask and find out after you've worked the code that, oh, Nana had a DNR, but we didn't ask, so we didn't get it on the way to the hospital. Then it's just, there's just a lot of legal red tape around that whole topic in general, but there's a lot of, I don't want to say gray area because it's legal document, it's final say, but I feel every couple years the question comes up of can medical POA overrule that? My answer is I don't know. Personally, if I was on scene and we're working a code on someone and family members there, I'm medical POA, I don't want you to work it, or we're not working them, and I do want you to work it, but they have a DNR, I would call and ask because a physician does have, to my knowledge, I could be wrong, a physician does have the ability to override that. So I would call up Cabandias, Williams, Godfrey, whoever, and let them know this situation. I have 97-year-old female. She has stage 4 breast cancer. This is what happened. This is what we've done so far. Do you want us to call it or keep going? They can override it, and then you just have to be very vigilant when documenting that. Um, Same thing with the MOLST form. It says they don't want to be bagged on the MOLST form. Family says they're not breathing. Shouldn't you be doing something about that? Well, this form right here says that she doesn't want us to breathe for her. Well, I'm her medical POA and I do want y'all to breathe for her. Let me make a phone call, see if I can, because this is a legal document. I think I think the root of the problem with most forms, DNRs, anything like that, living wills, anything like that, I think the root of the problem is that people don't understand it. Um, Now, I'm not saying that the fire department on that scenario that I was telling you about, I'm not saying that they didn't understand it. I'm saying that at the end of the day, they were just being negligent and lazy. Should they have acted like that? No. We did not act like that. We still got in there. We did all the things. We screened her for sepsis. I don't remember what ended up being wrong with her. I'm pretty sure she ended up being discharged. But I think like I said, I think it's just a lot of misinformation and not understanding what's going on. If the patient who has the DNR, if that was signed, they went over that with their doctor, and then agreed on it. Their doctor signed off on it, all that good stuff. In my opinion, it goes back to the whole being selfish thing. It's really and truly at that point, it's just the family member being selfish. If they are trying to get you to work it when you shouldn't be working it, again, it brings up a really awkward conversation. When people die, emotions run high. Emotions run high for family members, bystanders, people on scene sometimes. Um, so I've never had that happen, but if it did happen, I would like pull family aside, obviously if it was my code, but pull family aside and explain to them what was going on, explain to them why we're not working it, explain to them why we're not doing the things that we're doing, explain to them what a DNR actually means, and that means that the patient and the patient's doctor went over it and they agreed on it, and the doctor said that it would be a good idea, or they just agreed, yes, like this is something that it's okay for you to have. Excuse me. Because again, I feel like it's just a lot of misinformation and not understanding fully what a DNR means. I think family, like for the general public, people that aren't in healthcare, right? I think that they know what a DNR means, but like I said, when that time does come and someone does code or suffer cardiac arrest, they don't understand that like that's it. They want they want to feel helped. They want to feel seen. They want to feel like they are being heard for their concerns. And so that's where that communication with family or bystanders or whoever happens to be on scene, that's where that comes in. So you have to be very comfortable with having those awkward conversations and explaining to them, even if you are working a code, being positioned for talking to family, getting information, explaining to them what's happening. You have to be comfortable with having those really awkward conversations. Hey, I know your husband John was having chest pain this morning and has died. This is what we are doing. We are pushing on his chest so that we are beating his heart for him. We're circulating his blood for him. We are bagging him because he's not breathing, so we're breathing for him. The medication that you see going in his legs, this is epinephrine. This is what epinephrine is supposed to do in a cardiac arrest. And these giant stickers on his chest, when he jerks like that, that's us sending electricity through his heart to try and restart his heart and things like that. And you have to understand how to explain those kinds of things to people without coming off as condescending almost, or coming off as like patronizing, or like you're trying to belittle them and make them feel dumb. They already have enough going on. To be honest, even if you do use generic terms or layman's terms for things, they still might not even understand what's going on. But the important part of it is that you need to do your best to explain that to them. Um, they still might not be happy with the answer. Um, Usually, families pretty upset. Um, so like I said, it's a very awkward conversation to have with people, especially doing a death notification. But like they always tell us in CME, the biggest thing is to listen to what the family has to say, listen, hear them out on their concerns. And if you don't know, don't pretend that you do. Explain to them, I don't know the answer to that specific question. Let me see if I can get that answer for you. If there's another medic on scene, obviously don't go up to them while they're actively like defibrillating someone and be like, hey, do you know? Da, da, da. Um, I feel like most of the time, at least in Wake County, we have more resources than we need on a code. Usually, fire standing all over the place and police are standing all over the place. So, if it's something that one of them can answer, ask them. Try to get those answers to family members. Um, if not, you can point them in the direction of someone who might have the answer to that question. Um, like I said, biggest thing is just hearing them out, giving them the space to express their concerns and feel like they're being heard, because no one expects that to happen to their family member, husband, wife, whoever. So it's a very jarring experience. They're probably going to have a lot of questions. I've seen it either they have every question under the sun, or they're just so in shock that they don't even know how to tell you their patient's name or anything. So you just gotta understand what those forms mean. And I feel like school in general does not, they just assume everyone knows what that means. And so they don't, a lot of places don't take the time to explain that to you or explain what all of it entails and what to do with specific situations. So if you have questions, ask someone who knows. Chances are there's someone who's been doing this longer than you. They've probably seen everything. Ask them. If they don't know, ask somebody else. Um, don't just pretend like you know what's going on and then don't. Thanks for watching.